Parasternal long axis, septum, posterior wall. So just below the posterior wall is the pericardium. Okay. The posterior mitral leaflet, the anterior mitral leaflet, aortic valve, the aortic root, ascending aorta, right ventricle, left atrium. Okay, so you can see in diastole, the mitral valve opens. Okay, in systole, the aortic valve opens. Okay, and this heart is not contracting too well. So, okay, so this is a diastolic frame because the mitral valve is open. Okay, left atrium, left ventricle, posterior wall, septum. See, it's diastole, aortic valve is closed. This is your aortic root and the ascending aorta. This is the right ventricle. So when you look at the ECG on the bottom, your marker is right here. So this little red thing right there, that's the marker. And if you remember, diastole is from the end of the T wave to the QRS. So this is beyond the T wave. So again, the ECG is telling you that it's a diastolic frame. So again, parasternal long axis transduces in the third or fourth intercostal space, the marker towards the right shoulder, and you just adjust until you get the image that you're supposed to get. Okay, so color, you put color across all the valves and across all the structures. So let's look what we see here. So when we look across the aortic valve, you have to look closely now. Toward the end, there is a little jet here. Okay, so again, your transducer is right here. So, you have to do multiple manipulation to see what's going on. So one little view is not going to help you too much. Okay, and you can scroll through the color to see what's going on. I'll go back and show you what I mean by that. So you can always freeze. So you can, this is not too good. You can, so you can freeze it like that. And you can scroll through and see what's going on. Slowly. The thing when you're doing it in real time, you can use the knob and the machine to do simple scroll. So this looks suspicious for AI because it's Again, it's a diastolic frame, and it's, so it's so whatever it takes for you to identify what's going on, you need to do it. Okay. But you can scroll through, and it's much simpler on the Echo machine, much easier. And, your job is to properly diagnose what's happening to the patient. So you have to do a good study. If you don't do a good study, you're going to come up with something that's suboptimal. And okay, so the color is across the mitral valve, and we see this mosaic, probably mainly bluish color. Again, your transducer is here. So if this is blue, so the flow is moving away from the transducer, really. So it's a flow coming from the left ventricle across the mitral valve, and it's going into the left atrium. So this look huge. So the area of this look huge. So even if you don't know how to quantify mitral regurgitation, this look huge. And the first instinct is that's large, and then you wouldn't be incorrect, because this is significant mitral regurgitation. That's what it looks like. And you can, she froze it right there, and you can see the significant bluish color, which tell you that there's a flow from the LV going across the mitral valve into the left atrium. So that's mitral regurgitation. So you're going to put your color across all the valve. You're going to put it across the septum. You know, anywhere you can have abnormal flow, you're going to, because you can have abnormal flow across the septum. Okay. There's, we do our M mode, and we'll show you what the M mode is, but we do it across the aortic valve, we'll do it across the mitral valve, and we'll do it across the LV cavity. So remember, M mode was the stuff we did a million years ago, and it was the first echo modality that we had. You had to be very smart to to analyze it and interpret what's on, because you didn't, two-dimensional was not developed at that time. So all you had was those little markings, and you had to come up with good diagnosis. All right, so again, you need to remember how you do your measurement. The tip of the mitral leaflet in diastole, where the mitral valve is open, the aortic valve is closed, and you measure the septal thickness, LV cavity size in diastole, and the posterior wall thickness. And you need to know what's normal. Okay. So that's one of the things you have to know as well. What's normal figure. So you can when you have an abnormal number or figure, you can identify that. Okay. So we're not teaching this stuff, but the mitral valve looks a little bit thickened to me. The mitral valve is a little bit thickened, and it's probably not opening to the full extent, but we're not teaching that. So from the parasternal long axis view, you're gonna segue into usually the RV inflow view. That's the next view you would embark on, but you still have to do your measurements. Again, if you're going to measure the aortic root, it should be done in diastole. So this is incorrect. Okay, the aortic root should be measured in diastole, where the aortic valve is closed. Okay, your left atrial dimension, of course, it should be done where you have at the sinus of Valsalva, and it's a systolic measurement, so left atrial dimension. And in the exam, it's basic stuff they're going to test your knowledge on, you know. These are basic stuff that if you're going to scan, if you're doing any type of scan, you need to know. So, and, you know, fortunately, that's what they test you on. So the test's usually not a difficult test, but you have to know what you're doing. Again, you can zoom, remember, you can zoom, you can enlarge your, you know, your picture if you want to look at something in a larger frame, you can zoom it. You don't want to zoom too many of your images. So you need to get the images that is necessary to make an assessment, but you don't want to spend too much time. You don't want to waste time. You know? Your LVOT diameter, left ventricular outflow tract diameter, that is a systolic measurement where you have the aortic valve opens and it's a few millimeters in front of the aortic valve. Okay, and it's from the tissue blood plane. So you just come straight down. So that's the left ventricular flow tract diameter, and that measurement is important as when we start doing hemodynamic, you understand the significance of that. So measurements are very, very important. So you need to be able to do accurate measurements, because if your measurements are off, you're going to give the patient all type of disease, which they probably don't have, so you don't want to do that. Okay, so again, so this mosaic color going back, that is a mitral regurgitation. It is flow from the LV cavity across the mitral valve into the left atrium. It's mainly a bluish color because it's moving away from the transducer. So the color will tell you that there is mitral regurgitation. Then the next step is to quantify it, because you have moderate and severe. If the patient is symptomatic with severe mitral regurgitation, then that's an indication for mitral valve replacement or repair. So, the implication of making certain assessment and quantifying certain valvular pathologies for therapy. So color flow is extremely important. We use it to identify if there's a problem. Okay, so this is your RV flow view. So just for orientation purposes, the posterior leaflet is there. It's the anterior leaflet, the tricuspid valve. So it's your tricuspid valve, posterior leaflet, anterior leaflet. This is a right ventricle. This is the right atrium. Descending aorta is right there. Further up, you have the coronary sinus. The inferior vena cava is lowered down. So you have to know your structures, you have to go over those things numerous times until you commit it to memory. And then when you start scanning, then it will be fixed in your brain. All right, so this is your RV inflow view. And again, you're supposed to know how to get that view. What you do is you just tilt your transducer towards the patient's left shoulder or left axilla and just make certain adjustments. And just like all the valves, you're going to put your color. You put your color across the tricuspid valve, and you can see that there's a color. It tells you that there's a flow. So this is your transducer right there. There's a flow from the RV across the tricuspid valve going into the right atrium. So that's tricuspid regurgitation. So the color just identify it, and you just look at it. You can make a rough assessment. Is it mild, moderate, or severe? For quantification purposes, we have other tools that we use. Okay. So the color will identify that you have tricuspid regurgitation. Then your next approach is to quantify the tricuspid regurgitation. And you will learn how to do that once you can scan. This is a short axis at the level of the aorta, and this is the cursor. The sample volume is right there, and you see a tinge of tricuspid regurgitation, but you have to move your transducer around to get a good look at the flow. It's there because you saw it with the color, so you just have to manipulate the cursor and the transducer, so you can get decent flow. So you did manipulate it a little bit, and you see there's consistent flow here below the baseline in systole. Systole is from the onset of the QRS to the end of the T wave, so there's a systolic flow below the baseline. and it's telling you that something is flowing from the RV across the tricuspid into the right atrium, which is tricuspid regurgitation. Understanding short axis, the level of the aorta. You can see the aorta valve open. It opens in a triangular configuration. Okay, this is one cusp. It's another cusp. The next cusp is right there. With that, the atrial septum, that's the non-coronary cusp. You have to know your structures. Again, opens in a triangular configuration. If this is your atrial septum, then this will be the non-coronary cusp. This will be the right, and the left is right there. And the importance of that, if you see a vegetation on one of the cusp or one of the leaflet, you can, tell the surgeon, tell the cardiologist, which leaflet the vegetation is on, which leaflet is ruptured. So you need to know the different leaflets. Okay. So again, if this is the atrial septum, then the cusp that adjacent is the non-coronary. This will be the right, and this is the left. And these things stick by doing it over and over, and you have to scan. You can't just learn this thing in theory, without if you have to learn it. So if you pull the angle of the transducer upwards, you can get short axis at the base of the heart. And remember, you have the mitral valve at the base. This is a bit off-centered, but this is the mitral valve. Okay. So, you need to get your images centered so you get nice images, nice pictures. So this is all off-centered. So, you should pride yourself in doing good studies. I mean, not only pride yourself, but if it's not done properly, I'm going to send you back to do it. And most other persons who read these studies, I mean, you can't make faulty assessment, and that's so. It's best not to interpret the study, as opposed to making faulty assessment. Okay. This is the base of the heart where you have the mitral valve, and you can see the regurgitation. Okay, this is the anterior leaflet of the mitral valve. The posterior leaflet is down there, and this is the mitral regurgitation that we have seen in multiple views. Okay, so this is short axis to the level of the papillary muscle. So this is a nice image. You have the anterior lateral papillary muscle here, and this is the posterior medial muscle. If you remember the wall, this is the anterior wall up here. This is the inferior wall. The lateral wall is over here, but this portion of the lateral wall is the anterior lateral wall. This portion of the lateral wall is the inferior lateral wall. Your septum is right over here, and this is the inferior septum, and the anterior septum is right there. So this is fairly simple. Again, so still image of the. So this is the mid segment of the heart. So we look at the base where the mitral valve is. At the mid segment of the heart, remember this is short axis. You bread loaf in the heart. Just you lay the heart on the table and you just bread loafing it like you would cut a loaf of bread. So this is the apex. So this heart is dilated, and that's why it looks, is dilated and it's not contracting. So this is the apex of the heart. So the apex only have four segments: the anterior wall, the inferior, the lateral wall, and the septum. Okay, it's the apex, short axis. So this is your apical chamber view. So you're going to put the transducer or the probe at the apex of the heart. So you're going to feel for that, or at the mid clavicular line and the fourth or fifth intercostal space. The, the marker is going to be pointing towards the 4 or 5 o'clock position, and then the heart should stand straight up like this. This is the left ventricular cavity right there, the lateral wall. This is your septum. The apex is right there. The anterior mitral leaflet, the posterior mitral leaflet. This is the left atrium, and then you have the pulmonary veins, one here, one there. This is the atrial septum. This is the right atrium, ventricular septum, and this is the right ventricle. And you can see the heart. This is not contracting. So if you have seen a lot of if you have seen a lot of normal hearts, right away you know this is abnormal. It's not contracting. Okay, again, see, look at the heart, it's not contracting at all. So, so we put the color across the mitral valve, and you see this mosaic color, mainly blue, bluish color coming here. So the transducer is right there, so it's moving away from the transducer. So it's a flow from the left ventricle across the mitral valve into the left atrium. So it's mitral regurgitation, and it's a large amount because it goes all the way back. Okay, we have not discussed quantification of regurgitation, but that looks large. I mean, you don't have to know anything about echo. This is a large regurgitation. Okay, comes all the way back. So that's what mitral regurgitation looks like. So you identify it with a color, and then we have different modalities, different methods of quantification of the mitral regurgitation. And then regurgitation is a bluish color right there. So let's play it. You can see that there's something coming down there. It's a sort of bluish color because it's a flow away from the transducer. It's right there, you see. So that's tricuspid regurgitation. Tells you that there's a flow from the right ventricle across the tricuspid valve going into the right atrium. Tricuspid regurgitation. And then you do the same thing across the aortic valve. There may be a little bit, so you're gonna have to put you move your transducer around and you can put your Doppler. So the valve, the anterior leaflet. So you can zoom your structures to have a better look. Your descending aorta is right there. Okay. So if you want a better look at structures, zoom it and look at it. Okay, you see this huge amount of mitral regurgitation. So the color goes all the way back. It's a large. Again. Okay, so the cursor is across the mitral valve. The sample volume is at the tip of the mitral leaflet, and you're gonna do a pulse wave measure, and there's a flow above the baseline. So this is the baseline. So it's a flow above the baseline. The reason why it's above the baseline because you have a flow from the atrium going across the mitral valve into the left ventricle. So this is a normal flow of things in the heart. The transducer is right there, it's moving towards the transducer, and it's above the baseline. So this is the mitral inflow. You have your E velocity, the A velocity. Okay. Again, it's the color. It's very impressive. Okay. So again, the cursor is across the mitral valve. Sample volume is right at the mitral valve, and you get this. Well, you press C Doppler, continuous wave Doppler, because with mitral regurgitation, the velocity is usually more than 1.5 to 2 meters per second. So you can't use pulse wave Doppler, okay? You have to use continuous wave Doppler, C Doppler, okay? And you see the velocity is almost 4 meters per second. So, and this is what your C Doppler of mitral regurgitation looks like. It's fairly dense. Anyway, you don't need to know that, but it's a systolic flow because it's from the onset of the QRS to the T wave. So it's a systolic flow, and that's what mitral regurgitation is. It's below the baseline because your transducer is right there. The flow is from the LV cavity across the mitral valve into the left atrium. So it's moving away from the transducer. That's why it's below the baseline. And it's C Doppler. Continuous wave Doppler. So once you have velocity, and with velocity above 1.5 to 2 meters per second, you have to switch from P Doppler to continuous wave Doppler. So you have to know the the flows that you're going to measure using P Doppler and the flows that you're going to measure using C Doppler. Okay, so remember we talk about tissue Doppler. You're gonna, this is the mitral annulus, this is the cursor, this is the medial mitral annulus. You can also do it at the lateral mitral annulus. It's a form of pulse wave Doppler, but the velocities are much smaller. They're usually centimeters per second, not meters per second. So when you press the TDI button, TDI, tissue Doppler imaging, okay, you get a systolic flow because in systole, the base of the heart moves up. This is a transducer again, transducer is right there. In systole, the base of the heart moves upwards. So you get a systolic, it's going to be above the baseline, telling you that you have a systolic velocity. And in diastole, the base moves downward. But there are two components in diastole. There's what we call the E prime and the A prime. So systolic component, then you have an E prime and A prime. Systole, I mean, this is the S prime, and the reason why it's above the baseline because the septum is going to move up to the apex, upwards in systole. Okay, S prime, E prime, A prime, and you need to know what is so this is not the first time we're talking about that. If you guys are paying attention, so you do it in the medial mitral annulus and you also do it at the lateral mitral annulus. You just press that button. So TDI is tissue Doppler imaging, is a form of pulse wave Doppler. Okay, see for the lateral mitral annulus, you do the same thing. You get your S prime, which is a systolic component, and then you have two diastolic components, the E prime and the A. Okay, so she loves the mitral regurgitation. It looks beautiful, but you know, you can't spend all your time looking at it. You have to move on. Okay, so that's and you know, if you when the ejection fraction, when the contractility of the heart is this poor, when the ejection fraction is this poor, you can get blood clots in the apex of the heart because any structures in the heart that is not moving, the blood can stagnate and you can get clots. So putting the color, you can, you can see if there's any clots because if the color fills all the space, then there's no space occupying lesion. So if the color did not fill all the space, then there could be a space occupying lesion. we use contrast, and we'll go over all of that, but contrast is a much better tool to look for a mass or a blood clot in the apex. Okay. So, the color pretty much fills everything, so I don't think there's any clots there. But contrast, we have contrast that we can put inside the LV cavity, and if it fills the whole cavity, then there's no blood clot, there's no space occupying lesion. If it fills a portion and then leave, portion unfilled, then there may be a clot. Cursor is across the LVOT, across the aortic valve. Sample volume is written the LVOT, and you press P Doppler now, P Doppler, and you get the flow there, a flow there, a flow there, a flow there, and a flow there. So these are the LVOT, left ventricular outflow tract flows. Left ventricular outflow tract flows. You can trace around it, and you'll get what we call the TVI, time velocity integral. You can get the maximum velocity, you can get the mean velocity. Okay? We'll go over all of that. Hemodynamics will go into that. Okay? Okay. And so you do your PW, and you also need to do CW. So you're not only going to do PW, you do CW. You get the same thing. This is across the aortic valve, though. This is across the aortic valve, not the LVOT this time. So you need to do the cross the LVOT, left ventricular flow tract, and you need to do the flow across the aortic valve as well. So, it's a bit long, but we just went over everything that we use. And again, the color flows across the tricuspid valve. This is the TR right here. Okay. And we do the same thing. We're going to put the pulse wave Doppler across, sorry, the continuous wave Doppler across the tricuspid valve. We want to look at the tricuspid regurgitation. We use continuous wave Doppler because the velocity is usually more than 1.5 to 2 meters per second. So we use C Doppler, continuous wave Doppler. Okay, so this is it. So the velocity is about 3 meters, more than 3 meters. So, and it's below the baseline because your transducer is right there. The flow is from the right ventricle across the tricuspid valve into the right atrium. It's below the baseline. Okay. You can see the color again. So this is your two-chamber view. This is the inferior wall and your anterior wall. Okay. Remember how to get that view. Well, from the apical four-chamber view, you're going to counterclockwise your probe, and you'll get that image. And you do the same thing, color, showing you this is the mitral regurgitation. You've seen that. Okay, this is your three-chamber view. So if you do further counterclockwise rotation, you get the three-chamber view. This is the inferior lateral wall. This is the anterior septum. Okay, the LVOT is right there. Aortic valve is right there. Okay, so I think we went through most of the Dopplers, so you should have a fairly decent idea. Next week we'll start hemodynamics next week, and as I mentioned before, that requires you have a good understanding of Doppler, because hemodynamics is just pure Doppler. All right, so we're gonna let's look at this one. Okay, so basically we're going over the same thing, but you have to do it because your assessment should be um, from multiple windows, so it's necessary to do that. Okay, and then this is the subcostal view, the liver, the inferior vena cava, and you need to do your hepatic flow. Remember, the hepatic flow is a pulse wave Doppler assessment, and it has clinical significance, so you need to do it. All right, so we're gonna stop here, and